بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. I'm Nazik Elmalaika, Abessit Ahmed Hussein, a professor of pathology at the Faculty of Medicine of Durman Islamic University. It's of my pleasure to continue with you a recording about diseases of the small intestine. In the previous part of this session, we described the pathophysiology and pathology of congenital anomalies, obstructive lesions, and vascular lesions of the small intestine, as well as the inflammatory bowel diseases, Crohn's, and ulcerative colitis. In this session, I expect you, or we are going to describe the pathology and pathophysiology of malabsorption syndromes, 3 of them, and tumors of the small intestine, the common ones only. Specifically, I would like you to list the characteristic small bowel biopsy features of the common causes of malabsorption, celiac disease and Weber's disease, and describe the principal manifestations of the common neoplasms of the small intestine. To start with malabsorption, malabsorption is an abnormality in which there is abnormal absorption of food nutrients across the small bowel. Malabsorption, or the impairment of this malabsorption, can be of single or multiple nutrients, and the possible presentations or symptoms can be increased fat excretion, a stool with increased fatty content that float in the bowel, or with variable deficiencies of the vitamin, symptoms and signs of the variable deficiency of the vitamins, or proteins, or carbohydrates, or minerals, or water. It can be, as we said, of a single or multiple nutrients. They are not necessarily to include all the nutrients. The mechanism of malabsorption can be decreased digestion or decreased absorption or decreased transport of the absorbed products. So there are 3 mechanisms of malabsorption: decreased either digestion or absorption, or transport of absorbed products. And clinically, the patients may show weight loss, anorexia, very massive weight loss, abdominal distension, borborygmy, diarrhea, and or features of vitamin deficiencies. Malabsorption is a gluten-sensitive enteropathy. Gluten is the nutrient found in wheat, القمح, okay? Malabsorption is the gluten-sensitive enteropathy due to hypersensitivity to a product called gliadin, found in the gluten, okay? Hypersensitivity. So it is mainly a hypersensitivity reaction. It is like the autoimmune disorders. There is an abnormality or a hereditary background in patients with malabsorption. It is usually associated with HALA DQ2 or DQ8. HALA, human leukocyte antigen, DQ2 or 8, commonly found in patients with malabsorption to celiac disease. Celiac disease is the #1 cause of malabsorption. The diagnosis is usually by tissue biopsy that proves to show increased transglutaminase, okay? Endoscopy is another investigation. It shows mucosal scalloping and loss of mucosal folds. And microscopically, the tissue biopsy, when seen under microscopy, shows increased intraepithelial T lymphocytes, villus blunting, and increased plasma cells. As you see in the right picture, the above one is the normal mucosa. Normal biopsy under microscope, stained with H&E, hematoxylin and eosin. These are the villi. These are the crypts. Very normal villi. The lower one shows features of the celiac disease. This normal villus appearance or structure is absent here. Blunting of the villi. And at this epithelium here, there is a specific number of lymphocytes. In celiac disease, this number increased remarkably. There is increased intraepithelial T lymphocytes. Also in the lamina propria, there is increased plasma cells. These are the microscopic features of celiac disease, a common cause of malabsorption. The treatment is a gluten-free diet to avoid gluten. Patients with this disease are better to avoid eating breads or wheat. Okay. There is an association with enteropathy T lymphocytes, enteropathy associated T lymphocyte, T cell lymphoma. So celiac disease also carries a risk of malignancy. It can be, patients with celiac disease can develop T cell lymphoma called enteropathy associated T cell lymphoma. Another malabsorption syndrome is called tropical sprue. It is similar to celiac disease, but the mechanism, the pathophysiology is different. Similar morphology to celiac disease, but different disease process or mechanism or pathophysiology. It's thought to be secondary to aerobic bacteria contamination of a small bowel. So it is an infectious in the background. Clinical course, they present with diarrhea, weight loss, B12 folate deficiency, similar to celiac disease and other conditions of the small intestine. It is endemic to the Caribbean, Colombia, Mexico, India, and Southeast Asia regions. Microscopic findings, there is increased intraepithelial lymphocytes as the celiac disease with variable villus blunting. There is no marked villus blunting like celiac disease. The treatment differs. It is treated by tetracyclines and folate for 6 months because it is an infectious disease. A third syndrome that causes malabsorption is Weber's disease, which is an infection by Trophirema weibelii, a bacillus, intracellular bacillus. Bacilli in macrophages and cells throughout the body. It is common in the Caucasian, middle-aged males, and there is association with HALA B27. Also, it carries an inherited background or predisposition. Patients with Weber's disease carry human leukocyte antigen B12 27. It can present with malabsorption, fever, arthralgia, pain in the joints, enlarged lymph nodes, because this is an intracellular bacillus like that of the TB. Grossly, there is thickened and blunted mucosal folds, thickened and blunted mucosal fold. This is grossly. Microscopically, there is massive infiltration of lamina propria by foamy macrophages These are the forming macrophages in the lamina propria. Biforming macrophages containing periodic acid shift positive granules. Periodic acid BAS stain. This pinkish color is the intracellular bacilli called Trophirema webelii. The treatment is with long-term antibiotics. There are other causes of malabsorption other than the three syndromes we mentioned, and these include bacterial overgrowth, non-specific villus planting, often due to decreased motility, disaccharide deficiency, and absorption evident with milk feeding, which causes explosive watery frothy stools and abdominal distension, or A-beta lipoproteinemia, another cause of malabsorption, in which there is a defect in the synthesis and export of apoprotein B from the intestinal mucosal cells, or a microvillus inclusion disease, which is a defect in the intestinal cytoskeleton, clear vacuoles in surface epithelium. There are clear vacuoles in the surface epithelium. So these are other 4 causes for malabsorption: bacterial overgrowth, disaccharide deficiency, A-beta lipoproteinemia, and microvillus inclusion disease. We come to bowel diseases or tumors. Generally, they are not common. They account for less than 6% of the GI tumors. So tumors of the small intestine are rare, accounting for only 6% of the GI tumors. They can be benign or malignant lesions. The common benign lesions are leiomyoma, in which there is increased proliferation of the smooth muscle cells, or adenoma, increased proliferation of the glands. And the malignant tumors include, this is adenoma, this is tubular adenoma, increased proliferation of the glandular structure, okay? Or malignant adenocarcinoma, malignant transformation of these glands, or neuroendocrine tumors, previously known as carcinoid, and these are composed of nests of hyperchromatic nuclei with salt and pepper appearance. Obvious nuclei with salt and pepper appearance, or lymphoma, or sarcoma. To summarize our session about the diseases of the small intestine, we talked about the mecal diverticulum, which is one of the congenital abnormalities of the small intestine, in which there is failure of involution of the omphalomesentéric duct. It usually occurs in the distal ileum, and don't forget the role of tooth in Meckel's diverticulum. Crohn's disease, which causes patch distribution or skip lesions and copplestone pattern macroscopically, and full thickness inflammatory extension or transmural inflammation, is one of the irritable or inflammatory bowel diseases. Another inflammatory bowel disease is celiac disease. Celiac disease is one of the malabsorption disorders or syndromes. The pathophysiology is immunological. There is hypersensitivity to the gliadin. There is increased transglutaminases. There is increased intraepithelial lymphocytes microscopically, and villus planting. Loss of the normal architecture of the villi. Tropical sprue is another cause of malabsorption. It is endemic in certain areas. It is of an infectious etiology, unlike the celiac. There is increased intraepithelial lymphocytes as well, but with variable villus blunting. Weber disease and a third syndrome of malabsorption. It is an infectious caused by an intracellular bacilli called Trophirema webelii. Microscopically, we find foamy macrophages in the lamina propria. These bacilli can be identified by the periodic acid shift, periodic acid BAS stain. The neoplasm of small intestine are rare. The benign ones are called adenoma, which can be villous or tubular, or adenocarcinoma, the malignant transformation of the glandular structure, and the neuroendocrine tumors, previously called as carcinoma tumors. That is all about our session about the diseases of the small intestine. And if you have any question, please do not hesitate to send me at this email, Nazik Elmalaika at oiu.edu.st. Wassalamu alaikum wa rahmatullahi wa barakatuh.